Okay, I think there are people joining, but it's probably best that we make a start. Unfortunately, James is a bit tied up at the moment, so I will just be chairing the session for today. So thanks for making the time to join this session, particularly on a very nice sunny afternoon. I think it's going to be the hottest day of the year by the sounds of it. So if you're indoors and joining the session, thank you very much. So what we're going to do today, it's the third session in the NCITA webinar series. And the first session and the second session were really concentrating on how NCITA repository and QA/QC systems might help to develop and move forward imaging trials and some experiences along those lines. So this is really going to be talking about imaging trials themselves. How do you design a good imaging trial? What does a late phase or an early phase study look like? And so the speakers today are hopefully going to give you a flavor of their experiences in doing imaging research and actually translating imaging into the clinic. So we've got three people who will be speaking today. First is Professor Sue Mallett, who will be speaking about imaging statistics, and she's based at UCL. Following that, it will be Professor Hashim Ahmed, who's at Imperial, who you probably heard of in relation to multiparametric MRI and how that's actually changed the national guidelines on how prostate cancer should be imaged. And then finally, I'll be presenting a little bit of information about how we are developing new imaging technologies and in my particular area, which is also related to prostate cancer. So not to delay any further, we can hand the floor over to Professor Sue Mallett, who will be able to share the screen with us fairly soon, we hope. Sue, over to you.
Hi, thank you very much, Shonit, for introducing that. Right, let me get my screen. There we go. Hopefully that's right. Can everyone hear me and can you see my screen?
Yes.
That's a yes, great. Fantastic. Hi, thank you very much for inviting me. My name's Sue Mallett. I'm a professor in diagnostic and prognostic medical statistics, and I've just started at UCL. And so I'm going to talk today a bit about designing imaging studies. And first thing I want to say, right, just check I can get to the next slide. It's showing me the next slide on my screen, but not maybe on yours. Right, let me try again. Oh, okay, yes. First thing I would say is your research time is valuable, and it's really, really valuable. And I want to share with you a quote I find quite inspiring from a lady called Maya Angelou, which is, do the best you can until you know better. And when you know better, do better. So I wanted to really start off by saying there's a little bit of a problem in medical research, and it's a bit of a dirty secret, to be honest. So a lot of medical research is not done very well. 26 years ago now, Doug Altman wrote this piece called The Scandal of Poor Medical Research, basically saying that a lot of medical research is not really using the right methods. Everyone's following what someone else did, and it's not really, it's not really getting us the right answers to the right questions. And so that was 26 years ago. Surely we've all come along since then. But 2005, John Ioannidis, and again, if you've not followed his stuff, I would recommend his work. He published an article called Why Most Public Research Findings Are False. Okay, and that's a great read. And it's, unfortunately, you feel like 10 years on from the scandal of poor medical research, did we really need to be told that we need to keep improving our methods? And again, 2018, unfortunately, a further publication saying research waste is still a scandal. So I think, let's all work together and do the best we can. So, and why we need to do the best we can is that your research time is valuable. It's really, really valuable. And, you want to be answering important questions. You want to be collecting the right data. You want to be thinking about how you present your data. And I'm using data rather than meaning actual data. Thinking about how you express your results, think about the role of your biomarker. Most of you are working on biomarkers and imaging, and thinking about who to enroll in your study and how you're going to report your study so it can be useful to other people. Okay, so here's a typical question. Is my biomarker correlated to my outcome? Okay, answer, R squared equals 0.7, and this one's quite, got a fancy 95% confidence interval, like 0.55 to 0.85. Okay, what did I learn from that? Well, actually, I feel like I'm in a bit of a black hole when I see those answers. I'm like, well, someone's trying to tell me it correlates quite well, but I have no idea. So we could actually rephrase that, and we could say, what's the relationship of my biomarker to my study outcome? And here's a little graph from a study by Imperial from one of the CRASH 2 trials. And what it's got is the risk of death, which is on the y-axis here. And you've got the biomarker, which is capillary refill time, which is on the x-axis. And here you actually really have a good feeling that you know what the relationship is of this capillary refill time, his biomarker with risk of death. Okay. So I thought, well, I'm going to go off and I'm going to find a really nice example from bioimaging. And so I put a biomarkers imaging into Google, and I thought, great, I'll look at all the pictures, and I found this picture, and I thought, wow, that's great. That's a bioimaging marker study that's showing the individual patients. So each of these dots on this scatter plot is an individual patient, and I've got the biomarker on the y-axis. I've got something else on the x-axis. And it's looking at the neuroimaging markers association with Alzheimer's disease odor score. So their hypothesis is that you might be able to use smell, and they're using this odor score to actually diagnose Alzheimer's disease. And so that's part of what they're doing. And they've also decided to look at it with imaging biomarkers. And so this is one of many graphs in that paper. In fact, this is the graph that shows the best sort of relationship between this odor score and the imaging biomarker score. So I'm looking at this and I'm thinking, oh yeah, look, we've got an R, we've got a p-value, it's really significant. We've got a nice regression line, and then we've got confidence intervals. This is amazing. And then actually I thought, so what are the dots? What do the different colored dots means? And then I realized that the red was Alzheimer's patients, the blue were healthy controls. And I was sort of upset to read that they really were 20-year-old medical students who were the controls for the Alzheimer's patients. And the green is the partial cognitive impairment. So then I scratched my head a bit and I thought, hang on, actually, this is all about diagnosis of Alzheimer's. So I should be able to look at that imaging biomarker and say, what's the scatter of the red dots different from the scatter of the green ones or the blue ones? And I was like, oh. And then I realized that I was actually cutting out the whole of the x-axis. And actually, so that meant that the R score was not, the correlation was not important to me. The p-value was not important to me. The regression line was not important to me. The 95% confidence intervals were not important to me. And actually, I think they'd done the wrong correlation in the study. So I was like, okay, so they sort of, I guess by accident, they answered the wrong question. So that was a bit of a shame, really. Here's another example. So this actually came up in a journal club at Center for Medical Imaging. So it's about whether we can use liver stiffness on MRE to diagnose liver fibrosis. And here we've got they've got on this plot, we've got two different bars, and the smaller bar is if you're looking at a change in the MRE score of less than 15%, and the light purple, which is the bigger bar on the right-hand side, that's a change in MRE of greater than 15%. And the y-axis is an odds ratio for fibrosis progression. So they're saying, actually, if you've got this larger change in the MRE score, you've got a higher odds ratio of having liver fibrosis, and the confidence intervals don't include 1, so that's statistically significant. P-value is less than 0.05. And I sort of looked at it and I thought, I would just love to see the real data. And I thought, I'd love to see a graph a bit like Perel's graph. So I can actually get more of a grasp on this, because I feel, again, I'm a little bit in the black, a little bit of a black box here. And actually, then I thought of a study here that where we can actually see the individual patient data. So this is a graph. The question here is, when we're testing for HPV for cervical cancer in women, should the clinician take the swab to get the HPV sample, or should the patient themselves take it? And here we're actually measuring the amount of virus you get depending on who takes the swab. And so each sort of cross or triangle on here is a patient themselves. And you've got thresholds and everything, but you get a really different feeling when you can see that full data. Okay, so I think we can do that thing of let's present our actual data to people. So so then I was thinking, okay, what about, are we actually using the right statistic for our analysis? And Steve Halligan and others will recognize this study. So this is a CT colonography study looking for readers' performance with and without computer-aided detection. And we're looking for colorectal cancer. And so we'd done one study and we'd looked at sensitivity and specificity and how accurately the radiologists were diagnosing colorectal cancer with and without computer-assisted detection. And we were being asked as a next study, which was going for FDA licensing, to actually look at the difference in the ROC AUC. And so what I did is I was supposed to be calculating sample size. So I thought, okay, fine. What I'll do is I'll plot the thing that I understand, which is the increase in the number of patients with a correct diagnosis. I'll plot that on one axis, and then I can calculate, we've already done, the difference in the ROC AUC. And here's that graph. Now, each of these points is an individual radiologist. So if we look at point number 4, we can see at the bottom, next to the 6, we can see that actually this radiologist number 4 had increased their number of patients with the correct diagnosis by 6 when they used computer-assisted detection. And there were about 100 patients in their study. And if we look at another one, if we look at radiologist number 1, they increased the number of patients with the correct diagnosis by 2. Okay, but now if we look at what's the relationship of that? Something that I think hopefully we can all understand, the increase in the number of patients who got a correct diagnosis. We look at that relationship with the difference in the ROC AUC, and what you see is half of them look like they'd got a good result from using the CAD, so their difference in ROC AUC is a positive number. We might argue how positive does it have to be good enough, but the other ones were negative, and the ones that were negative, they had some really quite good increases in the number of patients with correct diagnoses. And so there was no relationship. So we actually thought about this, and we were thinking, well, if we use this difference in ROC AUC, which everyone else in that field was using for their licensing, would we actually be providing useful information? And so this led to a whole exploration of the problems with using ROC AUC and these confidence scores and everything. And again, it was a really interesting project, but the point here is to make sure that if you're going to use something that's, you're going to use as an outcome for your analysis, does it actually do what you would want it to do? Is it a useful thing to calculate? Okay, and so actually the story is we went back to what we'd always done, which was looking at sensitivity and specificity. And here you can see the graph where each arrow on here is a radiologist. So the bottom of the arrow is without the computer-assisted detection, and the top of the arrow, point of the arrow, is with the computer-assisted detection. And so, for us, that we looked at that and we're like, we actually feel we know what the computer-assisted detection is doing. It's increasing the number of true patients who are correctly diagnosed with disease, but you get a few more false positives as well. Okay, so that's thinking about what you're going to calculate in your analysis, and is it something meaningful? Is it worth making that calculation? So I thought I'd actually just touch on p-values. So there is a bit of a problem with p-values. One of the problems is, what does a p-value mean? Okay, so here's the definition of a p-value. If the null hypothesis was true, that's a sort of statistical speak that puts everyone off, doesn't it? Okay, so I've translated that for you. If there's no relationship between my biomarker and outcome, what would be the chance of observing results as extreme or even more extreme as the results observed in this particular experiment? That's actually what a p-value means. So it's not the probability of a positive result. It's not the strength of evidence. And it doesn't even stay at a similar value if you repeat your experiment. So this is a fantastic video. I'd urge you to go off and have a watch and a listen to. And what you see is that as you repeat your experiment, your p-value might go from 0.2 to 0.9 to 0.6 to 0.07, and it's dancing all over the place. And you're sort of thinking, should I be, is this useful? I better make sure I'm not making too many conclusions based on the exact value of this p-value, because it's just dancing all over the place. So statisticians prefer confidence intervals. And these are the sort of things that you probably can see on the right-hand side of the screen here. I've got the dot with the two little arms out there. I always enjoy teaching confidence intervals because I get students to explain it to each other. You just see a load of people in the lecture theatre moving their arms around, doing confidence intervals with each other. Okay, and I've also put the Cochrane logo here because you can see there are the results with the confidence intervals, and that's what you're actually seeing in the Cochrane logo. So what is a confidence interval? So this is when we go from the study you've done to thinking about what the potential future studies might be if the study was repeated. And it's giving us that gauge of uncertainty around the results. So there's a great video from Dr. Nicola Petty on confidence intervals. I really urge you to have a listen to that one. That's a great watch. And here's an actual question I was asked by someone. I don't understand why I need to use confidence intervals. I've done an experiment, I've looked at the effect of a drug on 4 mice, I've got an exact result from my experiment. Why do I need a confidence interval around this result? Okay, and here's my answer. I hopefully put it quite tactfully, but it's like, we're not interested in the results from your experiment on your 4 mice. And we're not interested because his mice are dead now. So he kills them at the end of the experiment. What we're actually interested in is knowing what would happen of the likely impact of the drug on a population of mice or a different sample of mice. We want to know an estimate of the result and the uncertainty in these situations. And that's what we get for the 95% confidence intervals. So these things are really, really important. Okay, so let's come back. We've answered a few of those top ones. Let's think a little bit about the role of your biomarker and who you're going to enroll and reporting your study. Okay, so when you're thinking about your biomarker, you need to think about the stage of your study. Are you doing the first proof of concept and you're looking at association with disease? Are you proving that you can identify disease, you can separate disease and healthy? And in both of these, you've got severe and healthy patients as the people you're enrolling most likely. Or are you actually trying to prove that something could be clinically useful? And so you're looking at diagnostic accuracy, and you've got a set of patients who would actually attend the clinic. Okay, so early stage study, you might be developing an MRI signature for disease. A clinical stage study, you might be looking at diagnostic accuracy to detect disease. And another way you can look at it is you can think, what does my study look like when I go and do it? Does it look like this? I go to my computer and I find some images on there, and then I come up with some results that I either interpret or, I get other people to help me interpret. Or does it look like this? Do I have a set of patients who actually come to the clinic somewhere and we record their data on an organized form? We've got a protocol, we've got a stats analysis plan. And what we're really trying to do is input that result into guidelines. Okay, so the important point here is if you're in this bit, where you're in the earlier stages, if you're doing something about detecting disease, don't use sensitivity and specificity, because someone could interpret that and think that's about a clinical population. Okay, and if we look at an ideal test for prostate cancer, it might look like this. And we've got a biomarker, and the people without disease and with prostate cancer have completely different results, and they've got perfect separation, and we can put a threshold in there, no positive results, no false negatives. But actually it all looks like this, doesn't it? So some people get a false negative result because these results aren't perfectly separated for the people with and without disease. And some people get false positive results. And when we do our study, our early stage study, we've got some little stick men here you can see in green and red next to this early stage arrow. And they're really, again, if you have this threshold at 4, they get a perfect separation. And as we go through, we're looking at separating people with and without disease. Again, we've got a quite restricted set of people. And again, it looks perfect. When we get to that clinically relevant set of patients, it's quite likely some people will get false positive and some people get a false negative. So it's really important those early studies are not interpreted as if they and presented as if they're clinically relevant results. Another thing I think is really useful is to think about where your test would fit in to a patient pathway. And you might say, but I'm right at that early stage, I'm just investigating my biomarker. You know, why do I need to do this? You know, I'm just not at that clinical stage. Well, the thing is, if you do it, if you right at that early biomarker stage, you know where the test is going to be important. And you're thinking about its role, and you're thinking how important it is. When everything works with your experiments, your biomarker, you're going to have a really important result. But the problem is there are so many biomarkers that are investigated without any idea about how useful they would be. And they do a fantastic set of studies, take years and years, and at the end they go, oh, actually it's not really useful. Okay, so your time is really important, and it's really, really valuable. So see if you can think at where you are right in an early situation. And you might be thinking about whether your biomarker is replacing an existing test, triaging, or adding on. But just think about where it is in the pathway if you're doing some sort of biomarker, analysis. So here we are. We've been looking at all the questions and important questions and data and who to enroll. And let's think a little bit about you're looking at studies and you're saying, how should I look out? What should I look for as I evaluate a study design? How should I design my study? And what I really want to say is that risk of bias tools are really helpful. These are tools that methodologists and clinicians have developed together for looking at all the different stages in a study and thinking about what is in the design of the study. And there are the common risk of bias tools. You get a different risk of bias tool for a different design. So Qualis 2 is for diagnostic accuracy. There's a new one coming up, Qualis 2C, for comparison of diagnostic tests. That one's soon to come out. And then all sorts of other ones. So I would really, these things are really useful to help you think about the risk of bias in your study. They were developed for use in systematic reviews, but they're really good as a checklist to think about the design of your study that you're going to do. And as a sort of final thing, what I wanted to say is one thing you can really improve in your study, even if you've just finished it and it's all done, you can't change the design now, is you can think about how you report it and make it useful to others. And a really amazing resource is the NCITA website, where you can go and find different reporting guidelines. And I have people come to me and say, well, I don't need that because I'm really experienced and I've written so many articles like this before. And I can tell you that, I've written a lot of articles and helped with articles on diagnostic test accuracy. And every time I go and get out my starred checklist, because I want to make sure that I've got all 26 of those items that are recommended that you report to make your research useful to others. And usually I've got only 23 out of 26. That's, I think I'm doing quite well actually, but I can improve even at that really late stage, the day before I send the paper and submit it, I can improve my work and go by going up to that 26 out of 26 reported. Okay, so just to fit this into the NCITA Statistical Collaborative Team, so we're going to be mainly focused on studies that come through the CTU, and we'll be helping you collaborate with you to make sure that you've got the correct study design and that your statistical outcomes are suitable and pre-specified. And I'll be trying to talk you out of correlations, as you'll discover, or you may already have discovered. There's an expectation local sites will do their analysis. If you need help, come and discuss that. And what our aim is just to help you focus on analyses that can be interpreted, explained. We, steer you away from lots of p-values. Simple is better. Good presentation of results and studies. And I just want to leave you with this message: your research time is really, really valuable. Okay, so thank you. That was where I end. I'm going to stop sharing my screen.
Excellent. Thank you for that, Sue. That's a wonderful description of all the flaws with imaging studies. And so hopefully through working together in partnership via NCITA, we can try and improve the way that we conduct our research in this field. So Sue, I think what we'll do is we'll continue on to the next talk and then take questions at the end. So if people have questions, please do keep putting them onto the web chat, and then we'll read through those at the end and also have the opportunity for other people to ask personally at that time. So the next speaker I'd like to introduce again is Professor Hashim Ahmed, and he will be talking to us about multiparametric MRI in prostate cancer. Hashim.
Shonit, many thanks. It's a pleasure speaking to everyone today. Thank you for committing your time on a Friday afternoon and for those of you celebrating Eid, Eid Mubarak. So I'm going to talk about mainly about how we conceived, set up and delivered the large pivotal PROMISE study, which was set up to determine the validity of prostate multiparametric MRI in the diagnostic pathway for prostate cancer. So I have a number of conflicts, and I'm very grateful to the team who support me at Imperial at the moment, and my wider collaborators throughout the UK and internationally. The pathway has changed. I used to have this slide saying the errors that resulted from the current pathway, but it is now the previous pathway, and it should really be internationally. If a man has a clinical suspicion of prostate cancer, usually an elevated PSA blood test, or it could be an abnormal rectal nodule on examination, they would have normally gone on to a TRUS biopsy, a systematic sampling, pretty random, that finds indolent cancers by chance, that can miss important cancers and misclassify important as unimportant due to a glancing blow. And regardless of the burden or grade or the amount of cancer, men on the whole in the past used to go on to have whole gland treatment. And because the prostate is close to lots of critical structures, the risk of incontinence was anywhere between 10 and 20%. The risk of impotence is about 50% on average. And there is marginal gain in terms of mortality benefit over active monitoring. So the new strategy is to agree that not all cancers need treatment, and that there is an index lesion, maybe 2 index lesions in a prostate, which can often be identified by imaging and precision targeted biopsy, and that eventually, and I'm not going to talk about this in a huge amount of detail, we could adopt a lumpectomy approach where we target that index lesion in the majority of men who are suitable, and therefore reduce the harms of not only biopsy, but also treatment. So this means that in prostate cancer, we were about 10 years ago, about 30 years behind breast imaging and treatment. We're probably about 15 years behind still in terms of the treatment. And we used to use MRI after biopsy, but this picture shows you image 1 is pre-biopsy, and it shows a dark lesion where the arrow is pointing. That is the gentleman's tumor. And then if you image after biopsy up to 2 weeks, up to 3 months, 2 or 3 months, and even up to 6 months, you see biopsy artifacts. So inflammation and bleeding, hemosiderin deposition makes that entire area look abnormal, and you can't see the lesion. And in fact, it's harmful to do an MRI afterwards because often you start to overstage the disease as well. And it takes a number of months for those changes to go away. So doing a pre-biopsy MRI was the right way to find any lesion that was present. I'm just going to go through 3 cases to illustrate this. So this is a man with quite a high PSA, no particular family history. He had an MRI scan, which on T2 weighted imaging, on diffusion imaging, and on contrast enhancement was scored non-suspicious. And in those days, we used to still biopsy all of these men routinely. And in fact, he had a mapping biopsy, and I'll come on to that later on, which didn't show any cancer. So MRI seems not to find cancer, seems to be a good ruling out tool to triage men towards biopsy. This is another man who had an elevated PSA rising, and he had 2 negative biopsies over 5 years, and they were about to do his 3rd biopsy, and he asked for an MRI at UCLH. The T2 weighted image doesn't particularly show anything suspicious, but on diffusion, there's a large anterior tumor. For those of you who know about TRUS biopsy would biopsy the area lower down and not high up. And this man could have had 10 systematic biopsies and still not necessarily have found this aggressive area of disease. He went up, this is a high B value diffusion, nice light bulb effect showing up the tumor, and on contrast as well, a ground glass appearance. Finally had a template mapping biopsy, which showed that that area was high risk cancer. The figures in those boxes, in those circles, are the amount of cancer in millimeters. And he had, quite rightly, a radical prostatectomy, and that matched up to the MRI. Another gentleman with low-risk disease, quite high PSA, was found to have low-risk disease, and at that time was recommended to have radical therapy. He was concerned about the toxicity of radical therapy and went on to have an MRI scan, which showed a lesion in the right PZ, nothing else. This is on contrast. And this is on diffusion. The circles shifted a little bit, but it's, the lesion is lower down. And on template mapping biopsy, again, concordance. The MRI showed up the high-risk disease on the right-hand side, or moderate to high-risk disease, but actually didn't show up the low-risk disease on the left-hand side. That low-risk disease is the sort of cancer that the 30 to 40% of the male population above the age of 50 will have in their prostates. They will never know about it, and they will die of other causes. So MRI seems not to see these low volume, low risk cancers. And that was a key attribute that we felt was important in the pathway. If we could make sure men with low risk disease couldn't get a biopsy and therefore were never going to get diagnosed, and either have the burden of radical therapy for the rest of their life, or the burden of active surveillance and the anxiety of living with a cancer that wasn't being treated, but equally was not going to harm them. However, pretty pictures are one thing, but there was really a palpable lack of data. And this comment was made by an eminent researcher internationally during a conference at which one of our radiology colleagues, Claire Allen, presented almost 10 years ago now. You've shown us lots of pretty pictures, but where is the data? And that palpable lack of level 1 evidence is absolutely critical. And we were lucky in a sense that the NIHR HTA program launched a diagnostic studies call, and the stars aligned that our need at that moment in time was to evaluate prostate MRI. And so we set up, we applied for and got funding. It took about 2 or 3 years to set up the study, the PROMISE study, looking at validating the accuracy of MRI compared to an accurate reference standard. We're also comparing it to the standard test as well. And that was a critical design aspect that I'll come on to. Its objectives were to assess the ability of MRI, multiparametric MRI, prior to first biopsy to identify men who can safely avoid an unnecessary biopsy. So that Bossoit article from BMJ, it's the third pathway where we're looking at using MRI to triage men away from a biopsy. And that was a critical harm in the pathway that we wanted to avoid. The second harm that we wanted to avoid was overdiagnosis. That was the big issue. And the only reason you get overdiagnosed is if you have a needle stuck into your prostate. And so if we can avoid that, then you reduce the number of men being diagnosed with clinically insignificant cancer. And actually, as a result of the inaccuracy of trust biopsy, everybody knew this was happening, but the focus was on the harms of overdiagnosis. One of the focus that we felt was quite important was the fact that we were missing life-threatening cancers that were then progressing using a random systematic approach. And so we wanted to also show that we improved on the detection of life-threatening clinically significant cancer. Sue's spoke about the biases, and the biases in this pathway were multiple. And I just want to go through these individually. Firstly, most of the studies up until that point were validating or comparing MRI to men who have had their prostates out. So those men had to qualify in two ways. One, they had to have had a biopsy already. They had to have a positive cancer diagnosis on that biopsy. And actually the third one is that they had to also decide to have surgery. And there was some evidence at that time that men who chose surgery had slightly different burdens to those men who chose active surveillance, as you would expect, but also slightly different burden to those men who chose radiotherapy as well. So significant spectrum and selection bias. So we needed to evaluate men at risk. Now, how can we find out what the gold standard truth is, what the actual state of the prostate is without removing the prostate? And template mapping biopsies at that time was used in men who have already had a biopsy and where people were proposing to do a third or a sixth or an eighth biopsy. So mapping biopsy was a very accurate way of finding out what was going on in those men. And we had already conducted a number of studies, retrospective. In other words, in our clinical practice, we compared MRI to mapping biopsy and found very high sensitivity and good specificity. And so that was very reassuring, but retrospective and with some selection bias. So we decided to use the mapping biopsy. The index test, the MRI, we obviously needed to make sure that was blinded. And so the report was prospective and locked before the biopsy. A lot of the previous studies within the literature had consensus approaches where they had the biopsy and the MRIs side by side, or the pathology side by side, and you'd have to come up with a consensus as to whether the MRI was right or wrong. Clearly methodologically flawed if you're using retrospective data or even doing it prospectively, but allowing the index test report to be changed after you look at the reference test. And then there's obviously an expertise bias. At that time, and even now, there is a significant lack of expert trained radiologists. We think there might be a problem with this long term, and hence AI tools might be able to help us in the future. But nonetheless, at that time, you could probably count on a couple of hands the number of experts in Europe who could report a multiparametric MRI. So we needed to train people. We needed to show that this was reproducible across multiple reporters and multiple centers. So we had 2 training sessions. One of these training sessions were actually sometimes thrown back at us after the results came out. So commentators said, well, you know, you need to still train people, therefore this isn't quite ready for clinical practice, which is absolute nonsense. But everybody was very, very tied down to their biopsy gun. Urologists did not like this pathway 5 years ago. They love it now, but they absolutely hated the fact that they couldn't carry on doing biopsies. And MRI was going to take away a third of the biopsies that they had. And then there's obviously a need to look at in terms of a variability. And centers also needed to be of a mixed background, DGHs, as well as academic centers. And some centers, we had a few who just couldn't achieve the level of images that we needed, and they weren't able to qualify. But we had a qualification process and also ongoing case-by-case quality control using an external imaging CRO. At that time, it was IXICO. And then we also needed to compare the standard test to the reference test. And so that had to be also done. We had to be careful about the burden on the patient. And so the decision was made to do the standard test, the TRUS systematic blind biopsy at the same time as the reference test. Both of them were biopsy tests. The template had to be done under general anesthetic, and having men have the trust biopsy on a different day would mean they would either drop out of the study, so we would get attrition, or they just wouldn't take part because of the burden. So the decision was made to do those both under the same general anesthetic, and that meant that we had to decide the order. And we took the view that doing a transfecal biopsy first would risk sepsis on a greater level than it normally would. If you then put 50 to 60 biopsies, if you put 50 to 60 needles through the prostate after that with the reference test. That clearly meant that the trust biopsy could have been weakened in its accuracy. But we felt that it was balanced by the fact that men had it under general anesthetic, and therefore you probably had the best systematic trust biopsy than you would in a wriggling man screaming and shouting in your clinic room while you were doing it under local anesthetic. We made the biopsy operator blind to the imaging. They couldn't see the images on the PAC system, and that had technical challenges. You can imagine the discussions that we had with the hospital's governance systems to make sure that they were not released onto the PAC's wider view system until we had given the go-ahead. And the pathologist, for rightly or wrongly, was also blinded to any of the tests as well. So that was quite important. Whether we needed to blind them to the MRI, who knows? But a lot of the pathologists felt that MRI was not good enough. So perhaps there would have been bias creeping in when they were reporting the template biopsies. Who knows if they knew what the MRI report was. And patient bias. If the patient believed in MRI already and it was a negative MRI, they stood a greater chance of not having the biopsy, and we would then never get verification of the negative scans. And we were all biased. We wanted MRI to work. We knew we had to do a big study, but we wanted it to work. And so having an independent statistician and TSC was important. The reference test, as most of you will know, was this mapping test where we took biopsies every 5 millimeters throughout the prostate. And therefore, it was as accurate as you could get. What was extraordinary was that some of the criticism was that still this was not accurate enough, and you still had to do correlation to radical prostatectomy. And some people just didn't get it, that you couldn't do radical prostatectomy for the population that we were recruiting. Maybe some of them just didn't want to get it. It was one way of holding back the field. Not everybody agreed what the level of cancer should be for the target definition. We all agreed it shouldn't be every single bit of cancer, because 30 to 40% of the male population above the age of 50 had a little bit of cancer, so you couldn't use that as your target. But the actual threshold of significance was not, there was no acceptance around this. And in fact, the threshold of significance has been shifting almost every 5 or 6 years as we learn more about the natural history. The value of promise is that we can evaluate any threshold we want because we have all of that data locked. But we had to set it a priori to a threshold which we defined as UCL definition 1, promise definition 1, as indicated in the top right. We recruited, we got it completed. There were some withdrawals, but those withdrawals were blinded to the imaging. So there was no particular imbalance between those men who withdrew and those men who were still in the study. And we excelled our recruitment rate. And the results were quite remarkable. We confirmed that transrectal biopsy was really a bad test. An MRI was much more sensitive and able to act as a triage test to rule out the need for biopsy. And we estimated about 1/3 of men could avoid a biopsy. And in our current practice, in fact, about 40 to 50% of men can avoid a biopsy, because more research has shown that we can improve on the ruling out metrics of MRI. The poor specificity and PPV of MRI simply meant that in those men who had a suspicious MRI, you still needed to do a biopsy, because the false positives from atrophy, inflammation were still present, and you needed to confirm whether there was still cancer or not. Last two slides, these are things you won't have seen before, and that I haven't necessarily openly talked about before. Recruitment was initially poor. We had an optimistic view about recruitment. I think most of us do. We were quite naive at the beginning. We thought we could do with just a handful of centres. The funder was not impressed. We had a very strict chair of the panel who had an interim review, and we almost had our funding pulled. And had that happened, it would have set the field back by about 5 to 10 years. I truly believe that. The PROMISE study was so robust, it changed practice very quickly. That meant extra scrutiny, extra effort, but we brought more centres in, and there was an uptick in recruitment, and the HTA then started to calm down and leave us alone to complete the study. The biopsy burden was significant. Operating time was taken up at all of the centres, particularly UCLA, where we took on the greater burden of the recruitment. And there were NHS threats to close down the program. Pathology expense and resources for the template mapping biopsy. We had to change not the accuracy of the reference test, but the way we collected the biopsies, from core by core potting. So the pathologist would be presented with 60 pots each to be processed and reported on, to a zonal, so 20 zones, so 20 pots per prostate. But there was nonetheless a significant amount of burden, and we are immensely grateful to the two pathologists, Dr. Freeman and Dr. Jameson, who's now retired, for taking this work on. They in the end, and the NHS in the end, realized the importance of this and allowed us to continue. Equipoise is a real problem, even within study investigators. Some started to lose equipoise, maybe never had it in the first place because they truly believed in MRI, and that impacted on recruitment. The burden then fell on two researchers to get that recruitment going in the main centre. And there was significant concerns from radiologists about being tested, and that had an impact on the support for the study, and also in the way the reports were sometimes being done. So I think we would have found more negative MRIs if that feeling of being tested wasn't present. But that's a study trial bias that you'll find everywhere. And then there were certain concerns raised about ethics and governance. MRI outside of the study being offered and impacting on recruitment. There were public displays of aggression by others that I personally was being unethical. And there was even a GMC complaint against me for not offering MRI within standard of care. Stressful time, but it was cleared in the end, because clearly this study was absolutely needed in order to change guidance, which at that time did not permit doing an MRI scan. And the greater good was that we could not continue as one centre or two centres, UCLH and Imperial, being the only centres in the UK offering pre-biopsy MRI. There was a greater good, there was a greater need to do this study. If we were going to change the lives of 120,000 men every year, rather than a few hundred, we had to do this study. And I firmly believed that was the only way we were going to get the lives of those men improved. So in conclusion, robust evaluation of imaging in prostate cancer was a key international need. Equitable access to a technology required a practice and guideline changing study. There were significant challenges related to professional, academic, and resource issues. And whilst pre-biopsy MRI would have eventually been recommended, without promise, this would have been delayed by at least 5, if not 10 years. Thank you very much.
Excellent. Thank you, Hash. I mean, that's phenomenal. I mean, to outline what it takes to do a study which can change practice. You've also shown how, even if you've thought through the study, when it comes to delivery, how challenges arise that you just need to keep pushing through, and the determination it takes to actually take something from an idea all the way through to an end result. So thank you very much for sharing that. So I'm going to talk next, and I'm not going to talk about changing practice. I'm going to talk about the other end of the development of imaging biomarkers. So I'm going to see if I can share my screen, and then we can get started. Okay, is everyone able to see the screen? Or is anyone able to see the screen?
Yes, yes we are.
Brilliant. Okay, so I'm going to pick up where Hash left off. I mean, as Hash said, you know, the practice for the way men are managed with prostate cancer has completely changed now. But I'm going to talk a little bit about how we still need to do better than multiparametric MRI. And really this is focused, the talk I'm going to give is focused on what new techniques we've got and how we develop new techniques so that they can eventually get to a stage where you might want to be able to try them out in the sort of study that Hash has described. Okay, so early development, what is it that I'm talking about? And you may have seen the imaging biomarker roadmap that James had led on and published back in 2017, which is really trying to define a pipeline for development for imaging studies. The early bit I'm talking about is in this area. So this is about discovery and validation of new imaging biomarkers. And so it's quite far away from the studies that Hash is talking about, which are right at the other end of this pipeline. Okay, so why do we need to do something more for prostate cancer? Hash has basically said, you know, I've changed practice, it's done. And he's shown you some really nice pictures, and on these pictures you can see here is a patient with a T2 weighted scan, an axial image, a high B-value diffusion image, and contrast enhanced. And it's quite obvious that there are a couple of bright areas on here which enhance, and it's going to be a tumour. So it's done and dusted. Why do we need to change? Okay. He did say in his talk that there was something which was not perfect about MR. He said radiologists score scans, and here I've demonstrated a scoring system on Likert, but there's also a PIRAD scoring system. They score scan on likelihood of tumour, significant tumour being present. And here are the biopsies for a number of patients that had a lesion, who had a score attributed to the lesion, and these are the biopsied lesions only presented here. So you can see here that when radiologists score a Likert 5, it's pretty much perfect in picking up tumour. So there's no challenge there that needs to be remedied. Multiparametric MRI works. When radiologists score a Likert 2, you don't see a bar there, and that's because these men never got biopsied. So actually people are very happy to leave these men alone, and Hash showed you a very nice image of a man who had a completely normal MRI who wouldn't have been biopsied. But here is the challenge. If you look at radiology scores of 3 and 4, what you're trying to do is to pick up the orange and the red and differentiate them from the green, the insignificant tumours and the benign. So the real question is, how do you make a decision about men who have scored a 3 or even a 4 out of 5 for presence of tumour in terms of whether they get biopsies or not? And it's very difficult. You could try rescoring with PIRADs, and so these are the same men rescored with a different scoring system, but the problem still persists. And this is already after you've taken out men by using PSA density as a secondary measure by removing men with low PSA density from having biopsy. So this problem isn't going to go away, and it needs to be addressed. So that I've highlighted is the indeterminate proportion of men that you really don't know an outcome to based on your multiparameter MRI, and that's about 1/3 of men. The other thing I should highlight is that if you score a man as positive, you need to set a threshold on that 1 to 5 score as to what's positive. And most people are, if you set a threshold of 4 and 5 as positive, you'll find that 30% of men will go on to have a biopsy and will not have tumour. Whereas if you look at the 2 out of 5 scores and below, those negative men, 10% of men in that group do actually have tumour. So there is still a diagnostic accuracy area that needs to be improved. And the bigger problem actually is it's not about diagnostic accuracy, it's about prognostication. Because now you're finding a lot of men with tumour, but you know from various longitudinal studies that have been done that the majority of these men you find with tumour will not die from their cancer. So really, which ones do you treat and which ones do you leave alone? And there is no good test at the moment which will give you a good prognostication indicator. So we've been exploring MR-based approaches to identifying solutions to this. And so the questions we're asking is, look, we've got multiparametric MRI. It is providing anatomic and some sort of dynamic information and contrast enhanced. Can we get better techniques to give us more detailed information about microstructure of the prostate? And that might help us to better characterize some of those indeterminate lesions, those Leichhardt 3 and Leichhardt 4 ones, so we can avoid more men from having unnecessary biopsies. Or even better, can we look at the metabolism of tumors? And if we can assess the metabolism of tumors in vivo, can we look and predict those tumors that are going to be aggressive and separate those out from those which are not going to spread and metastasize? And here we have another opportunity to do that with a new MR technique. Okay, so microstructure. I want to talk a little bit about verdict MR. And so you may have seen some information on verdict. It's a technique we've been working on since about 2014. And the real reason I'm talking about this is because I want to illustrate the translational pipeline in the development of a new technology. And this relates back to some of the stuff that Sue was saying earlier in her talk in terms of how you might think about taking an imaging technique through to a stage where it's clinically valuable. So verdict MR it's really turning the question on its head in the way that it's approaching imaging. Mostly, if you are going to use imaging, you use standard MR sequences on a scanner and you ask a specific question. For, in this case, you could say, I want to take diffusion imaging, which is available on my scanner, and I want to see whether it can differentiate cancer from benign tissue in the prostate. But that imaging is not tailored to differentiate cancer from benign tissue. It's just tailored to give you a measurement of water movement, and that's it. But what you can do is you can actually go back, and the physicists in UCL came up with this. You can go back and you can look at the histology of tissue, and you can look at compartments and particular tissue components. And from that, understanding the difference in the ratios of different compartments between benign and cancer, you can create a mathematical model of those compartments, and then you can create an MRI sequence, which is based on diffusion imaging, which fills in the metrics parameters into this model, which will then allow you to generate a number of different metrics, parameters from the model, which you hope will be better at discriminating between significant and non-significant tumors in the men with a clinical challenge. So what does that take? Well, it takes a lot of time and it takes a lot of people to actually move anything along to get it to something that might be useful. So it starts off in the preclinical arena. And so in Verdict in 2014 is when the first article was published. So the work probably began a couple of years before this, and it was in the preclinical setting. And it demonstrated that, you know, in the mouse, you could get a signal from Verdict and you could separate out tumor areas and you could measure those parameters that we said we could measure. The next step is, can I do it in the man? In which case it's about translating the sequence that you've developed in the preclinical scanner onto a clinical scanner And at this stage, the only thing you're asking, this is a 9 or 10 patient study, the only thing you're asking is, does the signal that I produce in cancer look different than the signal that is not in cancer? i.e., does it work in those extreme cases that Sue was talking about, where the populations are already different? You just want to prove concept. And so it's just a normal versus abnormal study. And that was in 2015. We'll then go on to try and improve the technique, get some technical development in there. And we want to also demonstrate that biologically, the technique has some validity. So we want to do some histopathology correlative studies. And so there's some biological validation thrown in as another step forward. We then eventually get funding to do a clinical study. And that clinical study is now asking the question we wanted to ask at the very beginning, which is, can I differentiate between tumor and non-tumor in those areas which are scored as indeterminate by radiologists? And that's this INNOVATE trial, and this is the protocol paper from 2016. And we've just finished recruitment into that, published our early repeatability results from it to demonstrate that the imaging biomarkers are repeatable, reproducible, and early proof of concept demonstrates that they differentiate different Gleason grades, and that was published in 2019. That also demonstrated that actually, if you look at significant tumors and insignificant tumors, there is a good differentiation in the intracellular volume fraction, which is derived from verdict, between those two groups, which isn't really present on the non-tailored standard diffusion imaging that you get. And this was the article which was written as an editorial in Radiology, and they concluded that actually, you know, you can do complex things and you can deliver them in the clinic, and that you can increase diagnostic benefit. Nice editorial. I'm not sure I agree with either of the conclusions that they've made. So why do I say that? I say that because at the moment what we've done, what we've published, it has basically demonstrated that tumor and non-tumor differ in a population of patients, which is a subset from the verdict study, from an INNOVATE study. And what we really want to do is what Sue was saying, is to look at the population of patients that you really would apply this test in and to determine whether it has clinical value. We haven't done that yet. It's a bit like having a multiparametric MRI scan and producing a verdict map and saying the verdict map helps when clearly you can see the tumor on the right side of the multiparametric MRI anyway. It's not these patients we're interested in. So the other thing is what we've done is we've taken verdict and we've moved it from preclinical to single center evaluation. Again, the fact that it works in a single center and the fact we might show it has clinical value in the single center isn't going to take it over the line towards local adoption or regional adoption. It's that sort of multi-center study that Hash has described that really needs to be put in place if you want to move an imaging biomarker forward. And that's got to be a next step if we want to move verdict forward. But what I hope I've shown is we've taken individual steps along this translational pipeline sequentially to move it to a stage we can now think about a multi-center evaluative study. The other thing the editorial said is complex things can be delivered and they might be helpful. My view is actually simple things are probably better to be used, provided that they are helpful. And I want to just briefly talk about luminal water imaging, which is another technique that we're working on to assess microstructure. Here, we just use multi-echo T2 weighted images, and we try and separate out within individual pixels the T2 distribution of signals using a mathematical model. And here you can see, if you look at normal tissue, you've got cellular space, and then you've got this glandular space. This glandular space produces a high value for T2. The cellular space produces lower values distributions of T2. And you can also see that as you go from the normal state to progressively worse tumor, the glandular space disappears on histology. And actually that component of high T2 value also disappears. So if you take a ratio of the area under high T2 value peak versus the area under the high and the low T2 value peak, you can get a fraction, a luminal water fraction. And that luminal water fraction is correlated with Gleason grade. And why is this better, potentially better? Well, because T2 weighted images are much easier to acquire and can be set up on any scanner, and do not suffer from the same sort of artifacts as diffusion imaging, and they seem to correlate very well with what we want to measure, which is Gleason grade. So what does that actually look like in practice? So here's your multiparametric MRI. You've got T2 and diffusion images. Again, this is about proof of concept. You've got a tumor. There's no big difficulty in identifying it on standard imaging. But if you look at the luminal water fraction map, you can see the tumor really quite well outlined. And if you look at the distribution of T2 values in the normal area, you've got a very clear high peak, very small low T2 signal peak. And the opposite is true for the area which is tumor. So proof of concept, this can be done on scanners. It can be delivered in 3.5 to 4 minutes, and it actually helps you differentiate between different Gleason grades. Again, multiparametric MRI. So these patients have multiparametric MRI. Here's a lesion on the right side, which is scored by a radiologist as Likert 3, so indeterminate. Here is a luminal water fraction map from that area. And green is entirely normal. This is not normal nodular transition zone. I don't think there would be a question here about whether this lesion, which is indeterminate on multiparametric MRI, would be a normal or abnormal lesion on luminal water fraction map. And indeed, at biopsy, it was normal. On the other hand, here's another indeterminate left-sided focus on the multiparametric MRI. Red and yellow on the luminal water fraction map, biopsy positive. There are more examples. There's a Likert 4 lesion, which was scored by a radiologist Likert 4, entirely normal luminal water fraction map, benign biopsy. So those 3 and 4 scores, this is where something like this could really help you. When you've got a Likert 5 out of 5 lesion, it's very visible on normal imaging. And of course, it's very visible luminal water fraction, but that's not where the challenge is. So it's finding the right niche and the right clinical application. And so this study is now in submission for publication, and there are 2 large studies, multi-center, based on this technique, which will go forward. So to finish off, I just want to change the topic a little bit. So there we've talked about addressing the gap of how do we better select men for biopsy. With hyperpolarized MR, what I want to talk about is how you might be able to prognosticate. So we've been doing, not we, but MR has been used for metabolic imaging for a long time. And spectroscopy is one approach to this, where you can separate out signals from different metabolites. But there are a couple of things this slide illustrates. Firstly, you have to have very large volumes of voxels to get enough signal because the metabolite concentrations are small. The second thing is that you probably have to acquire for long periods of time, and it's fairly easy to do that. If you've got a static bit of tissue like the brain, it's much more difficult to do that if you've got mobile bits of tissue. And cancer, with cancers, I think one of the areas of interest is to image the Warburg effect. And so there is an opportunity here to image that using carbon-13 labeled metabolites, in this case, pyruvate. And that's what hyperpolarized MR allows us to do. Now, you can't do that with standard carbon-13 without hyperpolarizing, because the abundance of carbon-13 is very low, and the abundance of tissue is very low. So your signal you're going to get from that is going to be tiny. So hyperpolarization is really about how to boost the signal you get from carbon-13, and particularly from the signal that you'll inject into the carbon-13 pyruvate, which you'll inject into the patient, because background carbon-13 in humans is very low. So the various ways of doing that, and the best way, the easiest way, the simplest way, is actually just to get a really big magnet. So, 3T machines give you more signal, 1.5T machines. If you've got a 16 Tesla machine, you'll definitely have more signal. You might not have anywhere to put the magnet, but you'll have more signal. And actually, if you look at the equation, which demonstrates how much polarization you can get, if you can freeze the patient down to about 7 millikelvin, you'll get huge amounts of signal, although it might be impractical, the thawing process afterwards. So this is an easy way, but there are more complicated ways to do this, and there are a number of them. And DNP, dynamic nuclear polarization, is the one that seems to be getting into clinical practice. So what do you need? I want to go through the sort of process that we would take a new technology through, really new technology. What do you need? You need a place, a location where you can cite things, and here is a cancer center for us. You need an MRI machine, and then you need a DNP hyperpolarizer, which is what this machine is over here. So what is it? This is what it looks like inside. Here, you've got a 5 Tesla magnet, and you've got a cryo chamber, which you can get down to about 0.8 Kelvin. And you've got a microwave around it. And this is the inside of the machine. And the hyperpolarization process occurs in here, and the sample goes into this central area here. So what is the hyperpolarization process? Well, you get your carbon-13 labeled pyruvate. You place it in your hyperpolarizer, which is that microwave, which is in the freezer, which is in the magnet. And then you turn your microwave on for about 2 hours, maybe slightly longer, 2 to 3 hours. And as a consequence of that, you boost your signal within your carbon-13 pyruvate by about 10,000 times, which means you don't need very much to inject into a patient to get the signal. And the signal will come from wherever the pyruvate goes to, and also where the pyruvate converts to lactate, that Warburg effect in tumors. But here you're at 0 Kelvin, and pyruvate is an acid with a pH of about 1. So you need to convert it from 0 Kelvin into injectable material with a balanced pH fairly rapidly. So that DNP hyperpolarizer not only hyperpolarizes, it then melts the sample rapidly, pressurizes it, and sends it into a syringe. And then you have 3 minutes to run that syringe into the MR scanner and inject the patient. So this is the process. It's definitely more complicated, but it works. And the question is, in early phase stuff, how can you get this all to work? So the first thing is you get your hyperpolarizer, and you need to test that's actually working. So here is our first test. This is a polarization graph which shows a signal from a sample going up. This is the dissolution of the hyperpolarized solution, and this is the MR spectrometer that we've got in place to test that whether this signal that's present here is actually present in the sample. Then you need to change your MR machine, because actually MR machines produce signal using protons on water, and they're not really set up to do carbon-13 imaging. So you need to buy specialist coils, and you need to upgrade your MR machine to get signals from a different frequency from carbon-13. So this torture, this coil is essentially our first version of an endorectal coil, which was delivered to us and commissioned specially for prostate work. It's now got smaller since then, which was based on patient feedback. You then need to check that the coil is actually working and that you can generate signals. So there was a lot of phantom work done, and the sort of signals you generate tend to be squiggly lines. And as a radiologist, you tend not to like squiggly lines, so you then need to spend a lot of time to work out how you don't get squiggly lines, but you get images, and ideally color images of how much carbon-13 there is in a particular area. So this is all phantom work that needs to be done on your modified scanner. But really, you want to get on and do it for real. So you need to get your ethics in place. And if you thought getting ethics in place for standard imaging studies was difficult, for something where you're injecting something for the first time, or really for the first time in the population in the UK, you have to go through a lot of paperwork, including multiple SOPs and various revisions to get it done. You also need to work with friends, because actually this is the device that needs to be loaded into the hyperpolarizer. Here is the vial that the pyruvate would go in, and that vial doesn't come filled. It needs to be filled with sterile pyruvate, so that when you do boil it all off, it can be collected in this syringe, and that syringe can be run into the MR scanner. So that filling process needs to be done in a sterile environment. And this is our friends in the GMP facility who will help us to do this. And you can see that itself is a complex process which occurs in an isolator. Then you've got everything set up. You then read the small print on the paperwork that you're given from GE, which basically says you can't use this in humans. which is great, which essentially means that everything that you now do and you rely on in terms of safety, which is determined by your quality control module, which rapidly reads out all these readings, needs to be validated and qualified. So each of these numbers has a range between which we can inject, but you need to make sure that actually before you inject anyone, that that is working well and appropriately. So there's a lot of calibration, and these are just the SOPs, and a lot of pain that goes into calibrating and validating each of those components, including all the equipment that you're using to measure some of those signals. Eventually, you get to a stage where you can take delivery of a filled fluid bath. And so this is the night before our very first patient. The fluid bath was filled by 8:50 p.m. These guys are probably delivering this probably at about 10 p.m. Take delivery, and James, I think he's online today, is here loading up the fluid bath early morning working, because you need to have this polarizing for about 3 hours, and the patient turns up at 11 o'clock, so people need to get up early to make sure that everything's loaded and ready to go. And then there's more paperwork. And all of that results in 3 minutes of excitement. So I'm going to try and demonstrate what those 3 minutes of excitement look like on this video. So this is our very first patient with for prostate cancer scanned at UCH. So here we are in the MRI room. This is even before the patient has arrived and hyperpolarization stuff hasn't happened yet, but we need to make sure everything fits together well. You're not going to have any leaks in any lines that you're connecting up, because there are multiple connectors which are involved here. This is James within the hyperpolarized lab, and you can see the QC module there, and James is loading the various components into the QC module, which will produce the syringe that we want to then run off to the scanner. There's all the paperwork being filled in, and the various groups of people involved here. So you've got a QP standing in the background, and this is the dissolution. So this is the boiling off. You can see the yellow stuff go through. And then you hear that noise. That noise is a good noise. And previous times I've done this talk, I've said if it goes shh, bang, that's bad. So now you can take this out, and just to remind you, you've got 3 minutes roughly to inject this into a human. This is, again, our very first attempt at it. So you need to check, safety-wise, that's ready to go. So the QP will go through the various readings. And you need to check there's no particulate material in there. So there's a quick check of that. And then there's a secondary pH test that's going on. And all this time, you know, the signal from the injectable solution is disappearing exponentially fast. The first time we've done this, we were all fairly jittery. We go, Fiona running down the corridor. I'm walking. So we have the patient set up in the scanner. Everything is going to be connected, and then we're able to inject.
Okay.
Yep, everything's good to go.
Injecting now. Thank you.
Someone's gone.
Critical components to make sure it works. Okay, and then you get your scan done fairly rapidly. You can see where the prostate is, and you can see that there is a signal here, which is your peak of lactate. And that's kind of what you've done for the last 2.5 to 3 years in order to get a patient scan. Now you can convert that into an image, because we want images, and you can see that essentially turns out to be a red blob. Proof of concept that it works. Everyone is really happy team photo, and that's because it takes 3 years to go from nothing to your first in-man scanning. And then the final bit I would just say is that you've got to put up with this bit, the pain that comes afterwards, because the fact you can get it to work in one person doesn't mean you can get it to work in everyone. So here are our release criteria in order to determine whether we inject or not. And every time, these are the next 7 patients we attempted. First patient we attempted, the pH was out of range. Why? Because there's a blockage in here and the pyruvate didn't get out and we couldn't inject. The second patient we attempted, the pH was out of range. Why? Because actually the pyruvate ended up on the wall of the hyperpolarizer rather than in the syringe because the components exploded. Joint failure. Here's the third case. And actually, if you look very carefully, there is no real pH reading here. The solution looks really, really nice, ready to inject, but the errors all over the place. And why is that? It's because the various valves in this technology didn't open. And you can see how we've gone from a happy team photo to a very sad face. This guy's about to cry. Everyone's really unhappy by this time. And then you can go on where you've got no polarization. And this is, yeah, this is not good. I don't think we ever injected, we've got this into the hyperpolarizer, and I'm not going to mention who contributed to this, but I believe that Fiona is got SOPs in place to cover this now. And then you can get vial malfunctions, and you can continue, and you can get everything right. So case 7 is everything right. So here you go. Everything looks like it's injectable. There's no broken bits. The vial is still intact. And then, you know, you've got a really nice patient with prostate cancer ready to go. And if you've been eagle-eyed, you've probably spotted where the failure was in this case, because here on the coronal image, there is the prostate, and we ended up imaging the penis. So there are various ways to fail. And that's part of the learning curve of getting things to work and improving the process. And so just to finish on a high, this is the success rate now for filling and injecting, and our success rate in the last 20 patients, we've managed to inject 19 out of 20 and get good results. So it's a long process to go from concept into a technique where you can get it repeatedly working, and you can start thinking about the exploration of what it might mean. So in summary, early developmental work was what I've talked about. It's exciting and it's fun. Only do it, in my recommendation, is if there's a strong unmet clinical need that you're trying to fill. I'd also strongly recommend that you follow the translational pipeline, because you've got to take small steps along that to move things along. You've got to have multidisciplinary collaboration. You can't do it otherwise. And get some cash, because it's going to be expensive. You're not going to do your health economic analysis on early phase developmental work. And hopefully what I've shown you, you should be prepared to fail repeatedly, but you've got to have persistence, because that's the only way you're going to move things forward. This is really important early developmental work, because, you know, all the stuff, the later multi-center clinical trials, they're not going to happen because they'd be too risky to do without some foundation to build on. And in most cases, if they won't happen. If they do happen, there's a good chance they'll fail. And so finally, just to comment on NCITA, here at NCITA, the idea is that we provide you support across the translational pipeline to move an imaging biomarker along the pipeline in a systematic fashion, but also to be able to help deliver those multi-center studies at the other end of this that Hash has so well described. So thank you very much for your attention. Okay. So that's all in terms of talks. James, are you?
Yes, I'm here on land rather than the car now. Yeah, so thanks. I managed to catch pretty much all of that. I think there were 3 really interesting and good talks that flowed on really nicely from each other. So first of all, just see, are there any questions at all from the participants on the webinar? If you've got a question you want to ask yourself, please feel free to unmute and ask it, and please just obviously direct the question to the appropriate speaker. So Steve has got a hand up.
James, on the chat feature, there's a question from Nicola to Sue.
Okay. Well, okay. So Nicola's going to ask Sue one. Okay. So please go ahead. Nicola, are you there? Yep.
In the meantime, it's Steve. Can you hear me?
Yeah. Steve, let's go with you because we're.
Sorry, it just takes a bit of time to unmute, and we're all using about 20 different sorts of virtual software. It's difficult to remember which one you're using. Brilliant talks, really, really good. And I just really want to emphasise a few things, I think, rather than ask questions. I think Sue mentioned risk of bias tools and reporting guidelines. And one of the things I think it's really important to understand, as she said really, is that you tend to look at reporting guidelines when you've done your study. And then, whatever journal it is says, well, we need you to fill in this form. And then you think, shit, yeah, I better go and have a look at that. And you tend to look at risk of bias forms when you're doing a systematic review and a meta-analysis and you're trying to assess bias within studies. It's really, really important, like Sue says, to look at these before you even start your study, because by looking at the item, whatever it is that says, what blinding did you use? And you think, oh shit, I didn't use any blinding. I better use blinding in my protocol. So I think that there really needs to be a lot more advocation of using these tools at the design stage. I'm sure Sue would agree with that. The other thing I'd like to say, it relates to what Hash said about the PROMISE study and the fact that they overestimated recruitment. I mean, the general figure in the HTA is that recruitment is usually overestimated by about 75%. So if you think you're going to get 100 patients in your study, you're probably going to get about 25. And people never talk about the disasters like he spoke about. And I've done a few, and Stuart Taylor's done a few, and we've all done a few. And the disasters are horrendous. But you never, it's a disaster because you've got a study with 1,000 patients in it. A study with 20 patients in is easy to do. You never get, just as Hash says and as Shonit says, you never get research that changes guidelines and changes practice unless it's difficult. And unless it's a big study. And big studies are never easy. And it's a sad fact of life, but there it is. Put up with it and you'll do great research. That's it.
Okay. Thanks very much, Steve. Nicola, you are going to ask a question for Sue, I think.
I am, if you can hear me. Can somebody hear me? Yeah. I don't know what that was about. Sue, thank you. Those were brilliant talks to everybody, really enthusing. I wish I wasn't going on holiday next week now. But Sue, you had a slide that mentioned that local sites will conduct their own analysis. I'm not quite sure I understand that. Could you elaborate?
Yeah, I think at this very early stage, we're still recruiting a statistician, so we're not in a position to take on a lot of statistical analyses. And even when we will have one statistician, and there are lots of you with lots of studies going on. So we're going to have to prioritize, and we're going to have to work with you and discuss with you what the options are. So I know you'll all be doing, multiple sub-studies and lots of things. And there may be that in discussion with you, we decide that there's the primary outcome we can support you on, but we can't support you on all these sub-studies, or we've got to do a bit of negotiation, I think, here. I think you and me, Nicola, we need to also be discussing this and sorting ourselves out. But we're still at very early stages. I joined in middle of May, and we're still getting a team up together. And so we're still finding our feet here. So I would prefer to be prepared to do your local analysis and then be able to have the joy of offering you some more statistical backup and say we can do everything and we can't. That's really where I'm coming from. Does that help?
You. Yeah, absolutely. Thank you. Hopefully we'll move to a stage where we have the statisticians in-house and can offer that to everybody. Thanks.
Okay, any other questions? I can't see any other hands raised. Nicola,
again, sorry, me.
Yes, sir.
How many hyperpolarizers are there here, and in the UK and in Europe and everywhere?
Probably about 20, 23, something like that, installed across the world. In the UK, we probably have 5 of them.
Wow.
Yeah.
So Sean, I'd ask a question based on that. So with biomarkers that come from a technique such as hyperpolarized, where there's not just one machine, but there aren't many. Let's say we do discover a biomarker that does look as if it's useful, particularly say with something like prediction, where you might want to scan patients, effectively at their source or near to source hospital, and potentially use this for patient selection. Is that going to work? Have you got a fundamental problem there for technology unless you roll it out on a much bigger scale?
No, you're absolutely right. It's not going to work, and it's not going to work because the technology needs to catch up. So at this stage, where with hyperpolarized MR, we're at the cutting edge. Everything is expensive, and if we find that there is a potential clinical value in something, that's when the technology drive will be pushed forward. And so people are working on 2 areas. One is to get a small scale hyperpolarizer put in, which could go next to an MR machine, which would be much cheaper. And then the other area is to have central distribution and increase the half-life from 3 minutes to something like an hour. But those technology investments need to be spurred by early clinical potential. And that's where we are working on at the moment.